This is Going Under, Anesthesia Answered, with Dr. Brian Schmutzler. I'm Vahid Sadr-Zadeh, and we are brought to you by Butterfly Network.
We are. All right, I'm going to let you in on something that's completely changed the way I practice. I've been using Butterfly probes for years. It's a portable ultrasound that plugs right into my compatible smartphone or tablet, so I can start scanning at the bedside in seconds. If you use the older versions, I think the original IQ. I'm sorry, if you've used the older versions, or even if you're new to handheld ultrasound in general, let me tell you why this new IQ3 is a game-changing and really impressive. First off, having an ultrasound that literally fits in my pocket means I can move faster, whether it's vascular access, procedural guidance, or just getting real-time insights for my patients. And the tech inside this tiny device is pretty incredible. We learned a lot about that when we went to the POCUS forum. So this device has biplane imaging, which allows me to see short and long axis in the same view. Huge for procedural guidance and a great tool for learners. The new needle out of plane preset even shifts the scan plane, which you and I were talking about a little bit.
That's right.
Digitally, so I can see the needle tip sooner, which makes a real difference when precision matters. And the image quality is as good and honestly better than the cart base that I have. And really, that's impressive for something this portable. If you're looking for a device that supports your practice, I can't recommend the Butterfly IQ3 enough. And right now, they're running a special offer. You can get $750 off the latest IQ3. Check it out at butterflynetwork.com.
And speaking of the Butterfly Network, we've got somebody on the line across the pond that we met over there at the POCUS forum in West Palm?
Boca
Raton. I'm sorry. Yeah, Boca Raton. Close enough.
Yeah.
Boca Raton, Florida, a few weeks ago. And Dr. Lasserson, Dan Lasserson, is joining us here from London, England, or close to London. I know. Are you at the University of Warwick now, Dr. Lasserson?
I am. I'm in Warwick. So Warwick is it's a new university next to a very ancient city. Lots of English kings and lots of battles in the Median civil wars and things hundreds of years ago. But Warwick is a relatively new university, and it's a new medical school. And so we don't have the baggage of hundreds of years. Yeah.
When he says new, though, he means like 30, 40 years, right?
I think it's our 60-year anniversary, so it's a pretty new university for the UK.
That's an old university here, so yeah. But we're comparing to, Oxford and all those.
That's right.
All those ones that have been around for thousands of years.
Well, you've done you specialize in ambulatory care, but kind of the layman's terms would also be home care, right?
Yeah,
Is
hospital
at home.
Yeah.
So just kind of go over your background a little bit and how you got into that specialty. And what you're doing over there in England right now?
Yeah, it's a bit of a journey. And I think in the UK and perhaps everywhere in the world right now, people who find themselves delivering hospital at home have all had a bit of a journey because there's no set specialty or training for it. We kind of find our way there through I think being frustrated with how we deliver care through the traditional structures. So I started with a pretty sort of vanilla internal medicine training program. And then found myself when I was doing general acute medicine, geriatric medicine, getting frustrated that I was admitting patients to hospital to do, I thought, pretty simple things that I could do anywhere, but I could only do them in a hospital bed. And I then kind of changed track and did a family physician training and worked a couple of years as a family medic. And again, got frustrated because, yes, I'm with the patient in the home, but I've got no kit with me, right? And I'm not plugged into a network with advanced diagnostics, with advanced teaching, with other specialists that I would need to kind of have a phone a friend on if I'm managing a complex heart failure or a complex infectious diseases patient or a complex patient with, with metabolic abnormalities and diabetes. So, it struck me that the current either in the UK, you're either got everything in hospital or you've got nothing at home. But actually, there's this growing patient group who kind of want to be at home. But actually we don't train or have an infrastructure to provide that kind of internal medicine care for those patients to be treated outside hospital. And that's how I came to hospital home. So when I thought, actually, I can't come being a family medic, I want to go back into hospital, then I came back into hospital geriatrics, but did it by creating these ambulatory medical centres initially. And that was where patients who are acutely ill, who would ordinarily be admitted, would come to a unit and we would do diagnostics and treatment, give them intravenous treatment. They go home overnight, come back the next day for more IV treatment. So they spend the night in their own bed, but still get their hospital level care in the home. And of course, we thought we'd fix the problem. We thought we're geniuses. That's it. We can all just carry on doing this and life's great. And then we did some research that showed that for the real frail patients, they had a tough time doing that.
Even getting to your ambulatory clinic.
Yeah,
right?
even if we sent transport to pick them up and get them back safe to arranging themselves, the burden on them physically was huge, right? And it makes sense now. At the time, when you're in the middle of this unit, because we won awards and prizes, you think you're the hero, and you're not. You're just basically kicking the problem down the road, right? So we then thought, actually, we've now taken the acute internal medicine model from the hospital ward to a day unit. Let's take it further on that journey, left shift, if you like, into the home. So we've been thinking about this for a while, how we do it. And as you guys know, healthcare can be quite a risk-averse organisation and an industry for very good reasons. Because if you are going to change things, you'll make sure it's safe. It definitely is better than what you're doing now. Mm-hmm. But that can also be quite restrictive. So when COVID came, everyone was just so desperate to find a way to treat patients without bringing them to the hospitals, because the hospital, you was guaranteed to catch COVID. The nosocomial rates were so high. Right. And also, even if you could control the nosocomial infection, patients just wouldn't want to come. They think, well, I haven't got COVID now. I don't believe you. You can keep me safe in your hospital. And patients would be right about that, weren't they? So we were really looking for it. And then the manager's going to look, just find a way. Yeah. So so as long as you had a good logic model, you could evidence the safety of what you're doing, then actually that restrictiveness just kind of melted away, because you are coming not with a problem, you are coming with a solution. Yeah. And for me, and that's kind of, to sort of circle back as to why I met you guys, why was I in Boca Raton? It's because that for me, the biggest risk mitigation comes from knowing what you're treating, mm-hmm. and also knowing what you're not, what's there and what isn't there. Right. So your point of care diagnostics on day one, hour one, minute one of you getting to know a patient in hospital at home is it's you want to pack in as much information retrieval as possible to say, what's the risk I'm dealing with here? Because once you know that, you can then discuss and work your way through the patient once you know that.
And how did you pattern, like, what did you pattern hospital at home, the program you set up in England? What did you pattern that after? Was there somewhere that was already doing it? I mean, certainly it wasn't in the United States, but was there somewhere in, said Vienna's, like, for the conferences?
It's interesting. So hospital home as a concept had been going on, and in many ways, this is back to the future, right? You walk into any national portrait or picture gallery in any country, you will see 18th, 19th century pictures of a physician in the home with a candlelight and a patient sick on a bed, white, and a doctor somehow just holding the space in which this is all happening, right? So the physician trying to do work in the home has been there for ages. Then we bring in hospitals, and then we don't do it anymore, and now we come back to the future and go, actually, we've got to start doing it again. So there had always been some areas that were doing something called hospital home, but they weren't using diagnostics, very rarely giving intravenous treatments and oxygen. And they weren't looking to expand acuity or the model. It was doing what it was doing as it had always done. Okay. So what we did that was new was say, actually, we want to replace as much of that acute medical admission as possible. And we don't want to make hospital at home the kind of, poor cousin, right? You don't do it because you're not going to do something else. We want to make this almost like the business class option. You get to know exactly what's wrong. We get to spend less money. So the healthcare organization should love it. And patients get care that they want to receive. Yeah. And the reason why I think it took off is partly, the permissions were more rational during COVID, mm-hmm. rather than purely restrictive. It's because we're doing something that patients wanted and have always wanted and tell us they want more of, which is care in the home, or care as close to home as possible. And the more you allow the patient to speak about what they want and what they value, you end up doing less, spending less resource, using less drugs, less investigations. in a hospital bed, the politics are all wrong, the dynamics are wrong. The patient's in a gown, lying down, you're standing up over them. Okay, you'd be in scrubs in the US. In the UK, we'd be in our suit and bow tie and everything else. But we'd be, and we say, what do you want? And they go, well, you're the doc, you know. So whereas I find that when I'm in the own home, I say to a patient, you know, because we're both in our clothes, we're both sitting down, they're done, and I'm a guest in their home. You know, it's their they're not on my turf in the hospital. I'm on their turf. It's their territory.
Right.
They've allowed me in. So the dynamics are completely different. And I say, well, what do you want? What do you value? What are the limits here? And they tell me, and I get answers that I never get from the same kind of patients in
the
hospital.
hospital. So what metrics are you using, or I guess maybe even being forced to use by the hospital itself? What metrics are you using as this is success in hospital at home? Like what are they asking you for? They're asking for cost reduction.
That's a great question. So it depends who you're talking to, right? Because different people at the system, micro, meso, macro, value different things. So let's start at the helicopter overview. So I call it NHS England, which is a large organization that has been going for about 12 years, who's the kind of middleman. You've got what I guess our equivalent of the Department of Health and Human Services, which we call Department of Health and Social Care. And then at the bottom, you've got the healthcare deliverers. And then this big middle organization that takes the money from the government and works out how we spend it on providers. And it's a huge bureaucracy. In fact, today the government announced it's going to close it because they've realized, hang on a minute, it's basically duplicating the work of the Department of Health. So, but they have been they have been distributing the money, but then wanting their own data, separate Department of Health. So what they've been saying is, and they've got it wrong, okay, because they've said this is all about the number of quote unquote beds and what's your bed occupancy. So they're saying, have you always made sure you filled your virtual beds? And for a start, it kind of doesn't make any sense, right? Because how many virtual beds? Well, I can look after as many people as you refer. It kind of depends where they live and what's wrong with them, right?
Right.
So can I look after 100 people who've all got really complex fluid balance? They've all got positive blood cultures and they all live miles from each other. The answer is no, we probably can't do that matrix of complexity and distance and travel time.
But somebody who got a little cough that's an or a mildly symptomatic URI, you could see 1,000 of those, right?
But we want to see patients who would otherwise be in hospital. So we want patients where we're kind of getting intravenous treatment, where we can work out what our diagnosis is with our point of care testing, and where we can monitor them. So it kind of says, so the number of people we have will vary depending on kind of where they are and what's wrong, and we can always squeeze some more in the day depending on where we are. So we don't have a fixed number of people that we can look after. So the metrics they want don't kind of work. So we just we give them information, but it doesn't really matter what information is, okay, because it doesn't really reflect what we do. What we do, what I think the true metric is, how many days of hospital care have you replaced? And to do that, we look at what we're doing, what's our process of care.
Yeah.
And the process of care that I think is the most robust one are the days in which we give intravenous treatment and or oxygen, right? Because at the minute, you can only get those in hospital. Right. So if we're doing them in the home, we are absolutely 100% replacing a day of hospital care.
And what's a day of hospital care? So I'm just thinking in the United States, because I was just doing this data for some quality stuff. A day in the hospital in the United States costs roughly $3,000. So if I were to shift that to home, at least I have some comparison. Do you know what a day? Because we're talking about totally different healthcare systems, right? The United States is profit based, and insurance companies and blah blah blah. NHS is completely government subsidized, right? And so you don't have insurance companies, you don't have people, nobody pays into the system, but also nobody's taking billions of dollars out of the system for themselves. So there's no cash extraction from the NHS. You're right. Right.
It's funded by national insurance and tax. So everyone contributes a bit, but according to how much they're paid, not their intrinsic risk as an individual, to how much resource you might need to look after you. So there's a sort of set based on salary, and And it kind of varies, but I think it's around sort of £700 is kind of often what people quote for like a hospital day.
And what's that? Do you know what that equates to?
I think
about,
the U.S. dollar is not quite twice as much. Is
oh
it,
no, it's about 1.2. It's about 1.2 at the minute. So
okay,
so
it's like $1,000.
So
So it's like $1,000.
so about $1,000, yeah.
Yeah.
But then if you walk into an NHS, I mean, I've walked into some US hospitals; they're pretty nice. So I think you do get, although it costs more. I think a lot more goes on ambiance and other stuff.
It's a better hotel, yeah. Which actually I think maybe something that may hinder us doing hospital at home over here, right? Is because patients come in and it's good food, it's good. Well, it depends on the hospital, right? I've worked in downtown county hospitals that you don't necessarily want to spend the night in there, but then I've also worked at these bougie, single specialty,
the Erewhon of hospitals.
Exactly, yeah. So yeah.
Dr. Lasserson, I want to follow up on Brian's kind of question before, because I think it raises an interesting point here. Because first I want to let you answer, then I want to switch to Brian to see what he thinks about it. How much pushback or resistance have you gotten from government, from hospital systems there, about doing home care, that care at home and hospital at home?
So
how much and conversely, how much support have you gotten?
Yeah.
And then Brian, we're going to switch to you, because I want to know more about the United States way of thinking versus England and Europe.
So governments, because they know that they really can't pay the bills of healthcare, have always wanted to find ways that will, what they say, shift care from hospital to community.
Yeah.
And we've just had a review of, like, a diagnostic, what's wrong with our health system.
Yeah.
And because our hospitals are really congested. And what came back was we need a shift to shift more care from hospital into a community setting. So we've got this macro sort of helicopter covering fire, saying we've got to find a way to deliver more care without relying on hospitals. I think hospitals I see hospital at home as a way to kind of reinvent the hospital for the 21st, 22nd century. It's not a competition. It's not in the blue corner hospital, red corner hospital at home. It's actually, how do we reimagine the value and role of the hospital as we try and deliver more care that's outside of it, but maybe still using the intellectual capital and occasionally the process expertise, right? Yeah. So the government likes the idea, right? Individual hospitals like the idea, provided that we can do it without adding too much cost burden to them in terms of additional staff. Okay. Right. So we help their in-day problem. Every single within-day problem for a hospital is there's too many people in the emergency department, there's no beds in the hospital, and there's a stream of ambulances outside who are trying to transfer their patients into the hospital from the ambulance. And there's a lot of unknown risk. You're someone in an ambulance 10 deep in the queue. What's wrong with them? Have they had an MI? Is it all fine? Can they just go home? We don't know. Have they got a ruptured AAA? Or is it just back pain from a disc? Who knows, right? So you've got this undifferentiated and unknowable risk in an ambulance queue, where ideally you want to hook the patients out and get them sorted quickly if they need it, or if everything's fine, reassure them and send them home. And you've got an ED that's too full and can't work properly, and a hospital that's too full and can't work properly. So they are interested in finding ways to say, well, what can actually be generally treated outside hospital? The pushback comes. The only decent pushback I've had is actually from specialist societies, who
they're afraid you're going to take their work.
Well, it's weird, because it's not about taking their work. It's like it's work so it's almost like, they don't. It's not that we're taking it away. They've got too much of it already. Right. We're offering a solution, but they want to have more of their own problem. So it's not so, because it's actually perverse for them to push back against it, because actually we will be making their life easier. It's about the concept. It's the concept they just don't. It's somehow they've got antibodies to the concept of hospital home, and I find that it's particularly in the British Geriatric Society, where previously they really have not liked it at all. And I think some of this is it's quite a nuanced position to take. And I say that because one of the great successes of the British Geriatric Society is having equitable access to diagnostics and interventions regardless of age.
Yeah.
And so they've shown us that age truly is just a number, and we have much more frailty attuned services so that we're responding to frailty, not age. And to counteract the prevailing nihilism about diagnosis and intervention in the older adult.
Yeah, I think that makes sense in the US.
Yeah, it's a strong advocacy point. But then when you say, so they've spent 60 years as an organization saying, well, you must go to hospital. Hospitals must accept patients who are older. And then to suddenly go, actually, you'll go home again. It's fine. Don't come to hospital. It's quite a nuanced position. So it is often seen, or it lands in the heads of people as this is ageism. You're denying care. It kind of feeds into the trope of poor services that the BGS was set itself up to counteract.
Yeah.
And so all they saw was, this is the wrong thing to do. You guys are the problem, not the solution. And so that's where we've had only real pushback.
Gotcha.
We've had pushback from general practitioners and family physicians who go, hang on a minute, you're seeing patients in homes. We see people in homes. How dare you come and see people in their homes? So the people that even though would actually be lightening their load and doing complex work, the two groups where we've had pushback are from people where actually, they say they've got too much to do. We come along to say, here's, we'll do a bit less. And they go, no, you can't possibly, because of those antibodies to something that they feel that their core identity as physicians and their purpose in their professional life is being challenged.
Gotcha.
But you talk to the patients, they want this breakfast, lunch and dinner.
Right.
The question is not why are you doing this now? It's where the hell were you 10 years ago when I first had this problem when I wanted to be at home?
Right.
And what about my brother? He lives over there, and he can, my sister.
Can you help him too?
Why are you seeing her? Yeah. What's wrong with you guys? So we have these kind of trains in different directions. You're like, there's horses. There's some professionals who go, this is wrong, putting you in one direction. There's patients going, no, we want this, putting in the other direction, and the government going, come on, guys, just do more.
Yeah, I think in the U.S. the problem's going to be, or has been maybe, and I don't know. You spoke to, we didn't reference who it was, but a large prestigious university. I think hospitals, and I'm not sure they all know this, but hospitals get paid the more patients they get through the door, right? So I think that's going to be, there's going to be huge by CMS, by the insurance companies, by all that kind of stuff.
It's based on numbers. It's based on
number, complexity, and then they get facility fees. And I probably this is not the way it works in the NHS, but they get facility fees. So if there's an X-ray done, the hospital gets paid a certain amount for that X-ray getting done. If they have an MRI, they get paid for the MRI. They have XYZ in the hospital gets those facility fees. I wonder, and Dan, you and I talked a little bit about how CMS pays for hospital at home in the US. I wonder though, does the hospital get the facility fees? So if I take a butterfly and I do a POCUS exam and I see, there's a pericardial effusion, maybe I'll drain a little bit of that, or there's ascites and I'm going to drain the ascites. I don't know if the hospitals in the U.S. get those facility fees, which are substantial. So I wonder if that's part of the pushback of the American Hospital Association. And then in the U.S., the attorneys, that's going to be the other thing. Oh my gosh, you can't do that in a house. It's not sterile. It's not this. It's not that. It's not, you don't know what you're doing because, you're an internal medicine doctor. How could you possibly know how to do a, pericardiocentesis or drain ascites?
So what I don't understand about that though, I mean, obviously there's lawsuits sidestepping those landmines here in the United States. But what separates a house from a hospital from a home, right? The building protects you as a physician, as a,
it's perception. Just like Dan was saying, it's perception, right? The specialists and the family practice docs and the people out there who say, oh, well, you're it's the perception of you're doing something that you shouldn't be doing. That's my job to do, or that this is the wrong place to do it. So I think it's just perception. I don't think there's any real, and Dan, correct me if I'm wrong, but I don't think there's any real issue at all.
There is. So we spend a lot of our time developing ways to give intravenous treatment in the home. And sometimes we're using the same cannulas, the same venflons, using the same drug. we may change the infusion rate, we may change some things around it. I'll get it once a day or twice a day rather than multiple times a day, just because of visits and pragmatism. But ultimately, there's this book that Medusa that tells you how to safely deliver medicines.
Oh yeah.
And whenever someone says that can never be done in a home, this book says it can't be done at home. And I go, no, it doesn't do actually. This book says nothing about the zip code where you give the drug. It's about the biology, not the zip code.
And the pharmacology,
So and the only thing that varies with zip code is the building, the biology, the pharmacoepi, the pharmacology, everything else is the same, right? And there are medications that like intravenous iron is a great example. Everyone gets terrified about intravenous iron, but actually with modern compounds, with iron carboxymaltose, it's the safest thing ever. Many antibiotics that we give at home are way more dangerous in terms of that. So we've given loads of IV iron at home without any problem at all. And when we present this data, there are committees upon committees in other hospitals go, oh no, it's far too dangerous. You go, but we're showing the data, we've done it. Here it is, it's okay. And there's a lot of mythology about what can only happen in hospital that people kind of inherit from the people that taught them and that they teach other people. And there's there's a lot of repeating myth, there's a lot of myth propagation. And what we do with hospital at home is it allows us to have a fire break and challenge all the myth propagation about, look, what has to be done in the hospital? Well, look, if I find somebody with my ultrasound, like an obstructed kidney that needs a nephrostomy or a stent, you're
doing that in the hospital. Yeah,
of course. But if I find that the kidney looks normal ultrasound, then actually, okay, this is a drug fluid infection problem. I can treat that with exactly the same drugs, exact same way, in a home, in an aged care facility, in an acute medical unit, in a ward. If they'll get exactly the same thing in the vein, right? And exactly the same changes to the routine meds.
You bring up a big point, and I think this is something we should explore more at some point. But the myths and it's handed down in medicine is huge. I mean, it's just the we do it this way because the guy that trained me did it this way, and they train this way, and they train this way. I mean, the big thing is like work hours, right? Like you have to be in the hospital for 90 to 100 hours a week in your training. It's just we have a lot of this stuff in medicine. It's probably the same in other industries too. But, I mean, we have a ton of this.
But I also feel like what we experienced and heard and saw in the POCUS forum, 90% of the world's population doesn't have access to medical care or hospitals. And a lot of what we saw in that forum was stories of doctors going out to third world countries, to countries that don't have access to that care, to give access to those people. So isn't it an innate responsibility of a physician, of maybe one of the reasons that you become a doctor or practice medicine, is to offer care, to find a solution for those that don't have access to it?
I mean, if you can do it in the middle of nowhere, Bangladesh, you certainly could do it in somebody's home in London or somebody's home in Indiana, right?
And so what is your answer to that? I mean, how do you think it forms here? How do you think it would become a norm here, if it ever would?
My hope is that Dan comes over here and can talk some of these crazy people who run our healthcare system into it. I mean, again, so in the U.S. we're so data based, right? There has to be a randomized control trial before we can do anything, right? Before the FDA approves it, before CMS approves it, before blah blah blah. So I mean, I think just having an example from somewhere else saying, hey, listen, it works for us, and then we've got to change the financial incentives, right? That's going to be the other big things. How do we get the financial incentives? But I don't want to get away from hospital at home, but we don't have forever here. So I do want to flip now to POCUS, because Dan, you do, so we talk about POCUS on here. I do sort of a small subset of POCUS. You do a huge array of POCUS things. And so, and speak a little bit about POCUS, but also speak about point of care, some of the other stuff you do, right? You use iStats, you use, all kinds of things for point of care, not just ultrasound. So I just wanted to kind of give you the opening to talk about, POCUS and point of care and how that all rolls into your practice.
So I think this is the framework that allows me to do what I do. And the whole reason why feel like I could step into hospital at home was because I was taking diagnostics with me. Because as 16 years ago, as a family physician, I'd walk into someone's home, I'd have my eyes, ears, and my hands.
And stethoscope,
and
right? The
stethoscope. And a stethoscope, if I could hear anything through it. And that'd be it. And that'd be I might have a blood glucose reading, maybe a ketone glucose reading, but that'd be about it. And thinking, what can I handle here? What can I confidently diagnose and manage? And the answer is, some stuff. But once people start to get acutely sick, you kind of run out of information pretty quickly.
Right.
And then you've got undifferentiated risk, and also you can't intervene because you don't know which bag of fluid to reach for, which drug to reach for. So it became pretty clear to me at previous experience that if I was going to do home hospital properly, I'd need to take my diagnostics with me. And then as the years went on, we've all seen the changes in the handheld ultrasound space. And then obviously, the price points has come down, so it's affordable to kind of a physician can buy one. And then I thought, I've got to learn this. Because I'm not going to be able to transform the hospital at home space unless I have this.
Who taught you?
So I was really lucky to meet someone called Saab Claire. She's an amazing acute physician. I think we all have our heroes, and she's one of mine. And she did two things. One, she taught me how to ultrasound and echo. And two, she taught me to believe that I could do what I wanted with it. And both are important, because there's a lot of guys out there who can ultrasound and echo, but how many came to the POCUS forum, right? I think people who had that belief or were facilitated by the people around to go, no, you can change the service, you can do something new, and you can take this probe with you, and you can believe the results, and you can act on it, and you can build a whole framework of care or model of care based on that. And we'd all done that, I think, in that meeting, one way or another.
Yeah.
And so she gave me those two things that are important: A, the skills, and B, the empowerment. And then I thought, I can do this now. And then we just started doing it. And then it became, organizational learning, case by case. The first time so if I went to someone and said, like, I want to treat COVID-19 pneumonitis at home with tocilizumab, the hospital could have gone, no way, it's ridiculous. Or if I'd said, look, I want to do large volume paracentesis without any HAS at all, any albumin solution, and they go, that'd be ridiculous, no way, too risky. Or I want to treat, subacute bacterial peritonitis. No, you can't possibly do that. Or, I want to treat, listeria bacteremias at home with budinurus. No, how ridiculous. Or I want to give acetazolamide and bumetanide and metolazone with massive effusions. That'd be ridiculous. Or I want to diagnose patients and do echoes and have a cardiologist to look at the echo remotely, and that's it. They don't get a departmental echo. They just have my point of care one. They're going, ridiculous. But case by case, each of those things happen because actually it's the right thing to do for this patient at this moment in time. Right. And then the other hospital specialist departments, particularly cardiology and infectious diseases, because it's acute internal medicine, right? So half the work's heart failure, the other half's infection, and tiny bits, weird
other
autoimmune
stuff.
diseases.
Yeah,
right?
Yeah.
So we're dealing a lot with common stuff, right? And so those two departments, you learn who your phone a friend is, right? And why do they trust us? Because we've got a common language. I can show an echo. So just this morning, I'm at the university today, but I did my ward round of 35 patients from here on Teams remotely, and I was reviewing the imaging because I teach the nurses to image, and I was reviewing the images, and there's an echo that I'd done a couple of days ago on a lady who's quite frail, new diagnosis of heart failure, and can we get her from her home all the way to the department for a 45-minute echo, waiting, and then going back again? Well, I've seen a cardiologist review, went, yep, no, it's this, great, doesn't need a departmental echo. So I've saved, a few kilograms of CO2 in a big ambulance taking a delirium back. I've saved a 45-minute echo slot in a really pressured department. So that person could then maybe go up onto the ward instead and do an urgent echo on the cardiothoracics unit instead. And we've got the right answer 6 weeks earlier than we would otherwise. So the patient wins first of all. B, the planet wins because there's less CO2. The cardiologist wins because there's no complex thing to review. It's just actually I just need a targeted answer, yes or no, in this lady, rather than trying to get 20 numbers no one's going to look at. So all these things, and for me, the ultrasound probe it's the it's the whole cascade of change happens because of it. So many things are different. The kind of patients we can treat, the service we can develop, the way in which I interact with specialists. And, so for me, the ultrasound has been because point of care bloods are great, they're critical, but imaging has its own power in terms of the diagnosis you can make, the specialists you can engage with, and I love being remote controlled by a hepatologist for our advanced liver patients, by a cardiologist. I love it. I love the remote control because I learned something new about the complexities, and that those guys know a lot because it's their specialty inside out. So my care gets better each time I do it. And I feel I'm delivering a much better wraparound care for the patient. You're in your own bed, but don't worry, a cardiologist has looked at this. It makes me feel like I'm doing something much more for the patients than just me trying to muddle through.
We were talking on our last podcast about how everything's changed. So I'm watching the show called The Pit. You should watch it. It's on Max, HBO Max, if you can get it over there. But everything's changed in the ER. So every single case that comes in this show, and it's pretty medically accurate, they're doing POCUS. Every single one. Every case comes in before nobody takes a stethoscope out. Nobody takes a nerve hammer, nothing, right? None of that stuff. They just grab the ultrasound and start scanning belly, chest, heart, all that kind of stuff. So it's crazy that the changes that POCUS has created in the healthcare system. So I've got two questions for you. Number one, what are the 3 most common POCUS tests that you're doing? So if I said, you look at your top 3, what are they?
Okay, so I guess we categorize it either by the organ or by the question I want to answer.
Sure.
Okay, let's do the organ. So
organ, let's do organ. Yeah.
It would be kidney, heart, lung.
Okay. Yep.
And the questions I want to answer the other way are: why is this patient's creatinine raised? The other question is, what is this patient's fluid status? And the third question is, why is this patient breathless?
Yeah.
And so sometimes I might put in, so I do a lot of jugular vein ultrasound as well.
Fluid status.
This is great. This is great stuff from America, right? So great American studies. It's brilliant. The idea is perfect because you guys do a lot more POCUS than anyone else. And one cardiac center, every patient had a right heart cath. They just looked at the JVP. But with ultrasound, and got the ruler out and went, we can basically tell you what the right heart cath says the right atrial pressure is. All you need is a ruler and an ultrasound. And I thought, wow, that's a really, really cheap and non-invasive way to measure the right atrial pressure. But it's great.
Yeah, you know how we used to do it? We used to, before POCUS, we used to drop a central line and put a line into the right heart and measure the pressure. That's what we used to do.
Yeah, it's amazing. I think all the stuff we used to do to kind of, because it's really important. Because actually, if you're not going, do I need to drive this system anymore? Well, it's like the commonest thing we do in medicine is IV fluid, and a lot of the time we probably give too much of it. And actually knowing what those driving pressures are, the right atrial pressures, it feels like one of the most important numbers to know or to estimate. So I can. It's weird because I get referrals from internists because I'm the only senior medic in a hospital in medicine that is a POCUS first clinician, right? I'm the only one.
Yeah.
And I had a referral from an on-call acute internist saying, look, the GP can't work out what's going on with the fluid of this patient. They want to refer them into hospital. They could either come in, get a chest X-ray, my resident doctor could press their ankles and I could listen to them, or you could go around an ultrasound to them. Can you go around an ultrasound? So I recognize that actually for the question being asked, my technology in the home is better than than the standard practice inherited from father to son and father to son of how they do things in the hospital is just, outdated,
So I don't want to put words in your mouth, but so I guess I'll ask this as a question. Could you do hospital at home without POCUS?
No.
Okay.
Well, I don't think it would be hospital at home. It would be offering some care at home.
Yeah.
But you would be missing a load of stuff, or you would be sending patients in, or you'd be saying
they don't need it. Yeah.
They don't need it. Or you'd be not sending patients in where you could make a meaningful difference from an alternative care pathway. So I think you would put the patients on the wrong side of the line. Either go, I'm not sure what this is, I better send you in, or I think it'll be okay, we'll be all right, you stay at home, and the patients would be on the wrong side of the line.
The way I look at it, it's almost like we're Superman now, right? Like we have X-ray vision. I can see everything inside somebody's body. And you do way more than this than I do, right? So the two main things that I do with POCUS, three if you count when I'm doing cardiac stuff. But so regional anesthesia, doing numbing blocks, gastric studies, so seeing if they've eaten, and if they've eaten, is it fluid or actual substances, and then we do a little bit of TE or TTE, right? So where we do a little bit of cardiac imaging. So those are kind of the three main things that I do. But you do a whole array. So very, very cool. All right, so this is where I want to flip to now, and then you looks like you got a question too. But
yeah, before we wrap it up,
yeah. So the thing you and I talked about, Dan, is how can our POCUS as anesthesia help you? And so what I'm proposing and what we've talked about, and we'll just throw it out to the ether here, is coming to you and trying to add some regional anesthesia to what you guys do for non-operative, for non-operative pain, right? So knee pain, back pain, rib fractures, that sort of stuff with hospital at home. So that's kind of where I see, potentially me, because I'm not an internist, I'm not a general practitioner. I'm not going to go do all those things you're doing. I would like to, emphasize that and try to get it brought here to the United States. But that's not something I personally am going to do. But my personal contribution, I hope, both over on the other side of the pond and here, is to get regional anesthesia, something we can do at home.
Because I think this would be and the reason why I think this is really important, okay, is that when I think of what is it that is going to really help me move the needle in hospital home, because there's some people that go, oh yeah, but you can't have this in hospital home, and here's why. And there are two things that are actually probably both anesthesia related, okay, around that. The first one is pain. And people are right. If we're only there once or twice a day, we're not going to be able to give multiple things. We don't put in PCAs, right? So if someone's got a pain syndrome alongside their condition, and falls and rib fractures is a big part of that. And sometimes we know that if we don't get on top of pain in rib fractures, patients can really end up in trouble. So controlling pain is a massive priority. So actually, for us to be able to have those blocks ultrasound guided and start offering that for patients would be huge. And that's a lot of patients that we could be helping that currently we can't. And the other thing is around breathlessness in patients. We've already got a diagnosis and treatment, but we're kind of the breathless. And I think that things like high flow nasal air, that's huge. Getting rid of the dead space, mucociliary escalator improvement, a little bit of PEEP, stuff that you anesthesiologists know inside out and do really frequently, right? And we don't touch. But actually, pain and breathlessness are probably the two symptoms that can be frightening for people, and they go, actually, I find it hard to be at home, and because the sense of the intensity of those symptoms is so much that I find out they want to be at home, but if the symptoms are too intense, they can't be. And those are two. And if we crack that, I think the world is our oyster. The home is our oyster. In fact,
there is a and I won't belabor this point too much, but there is a very cheap disposable device that gives you basically BiPAP. And I don't know if you guys have it over there. I can't remember what it's called. Supernova or something like that. We use it from time to time. Somebody who doesn't necessarily need a whole big BiPAP machine and doesn't need the CPAP machine and all that, but we just need to get them through either in surgery or post-operatively. So that's a good point. I didn't even think about that. All right, Vahid, what's your question?
Well, we asked two questions to every guest that comes on the podcast. One question for you, Dr. Lasserson, is if you had an opportunity to go back, would you do it all over again and choose the same path that you chose?
The answer's got to be yes, because I'll tell you why. Because I wouldn't have done what I've done for hospital at home had I not taken my different routes through. And I wouldn't have seen what I could do for hospital home without being frustrated as a physician in hospital or as a family physician in the home. And without those two, I wouldn't have done it. If I could go back, I'd want to do it quicker, so that I would have perhaps not got to my early 50s to find out the whole fun of doing all this stuff.
But you came to it right at the right time with POCUS. Like that. Right. That's the serendipity of the fact that you came to it right when POCUS got really
I think you're right. I
handheld
think-
ultrasound.
Really big,
Yeah.
right?
And we're
I think-
big on butterfly, obviously, but
Right.
when handheld ultrasounds became something that was cheap enough, accessible enough, and good enough for you to do it.
Yeah, I think I'll be that coiled spring waiting for the handheld segments to kind of suddenly go. This is a market that's now delivered for widespread. Yeah, and the image quality is improving all the time. I mean, we saw that in Florida, right? Where and just today I was reflecting on because I've changed up and have got a more modern version. And I mean, the image quality is just stunning. Frame rates, everything, the echo, the thing that really is really, because you could always reliably rule out hydronephrosis, with the IQ, that was always fine. But an echo and an IQ3 is a different beast. So seeing those differences is, just tells you actually this is and yet we haven't seen the change in the kind of crystal market. The crystal tech was sort of always good, but hasn't really changed much, right?
Right.
Whereas the kind of non-crystal market is really changing. That tech is really changing fast.
The crystal tech, the only thing that's changed is the screen quality, at least in my opinion, right? So the crystal tech, it's as good as it's going to get.
Yeah.
It's making a 4K screen, then an 8K screen, and now a 16K screen, right? So the picture coming from the ultrasound is the same. It's just how's it displaying. I think, like you said, the chip technology is crazy. All right, what's the second question?
Well, you're a professor, and so you talk to students every day. What is your message for potential doctors and providers and people who want to get into home care? And what is your message for them, and what would your advice be?
So message one is learn ultrasound as soon as possible in your training. If you're at medical school, learn now. If you're a doctor, what are you doing? Learn now.
Yeah.
And that's probably the number one, because with that you can care anywhere, and then that gives you the confidence to care anywhere. And also the confidence to kind of ring someone in another specialty and say, look, here's what I've got. What do you think? Because they'll engage with you because they can see the quality of what you're doing, and they can see you're someone that wants to get the right information that can engage a specialist who perhaps might not want to talk to you otherwise. They go, what are you doing? Right. Okay, now we know what you're doing. Fine, here's what I would do. Yeah. So it allows you to kind of, deliver that wraparound for the patient. And the other thing, I suppose, is that you got to learn when a no is when an organization saying no needs to be challenged.
Okay.
Because
that's just the start of the fight.
Oh yeah.
Because people, and that's something around having your dirty dozen of critical friends. Because there are people who would say no to me because they just don't know what I'm doing. And so I like to talk to the people that I like to get a no from someone that is aligned with what I want to do, because I think, okay, I'll listen to that no, because they are saying, actually, you've hit the buffers, you're about to go over the line, you don't realize it, and I'm here to help you. I'm your critical friend. So it's finding people whose no you trust because they're in your corner. They don't want you to get it wrong, but they're not going to be so conceptual. They're not going to have antibodies to what you're doing that they're just going to say no anyway. And it's learning with time. Who has antibodies is always going to say no, and who doesn't have antibodies, but when they say no, you've got to listen.
Yeah. Nice.
Awesome. Well, this has been fantastic conversation. And hopefully this is not the end of what you'll see or hear from Dr. Dan Lasserson with Dr. Brian Schmutzler, because something is in the works. We're not going to tell you what it is, but it's in the works, and we're excited about it.
Sort of already did, but
well, not the details, right? Not the details.
We're looking to have our own bilateral US-UK arrangement.
That's right.
Whatever the politicians are doing, we've got our own thing going.
That's right. No means yes. No means go. That's right.
Oh, all right. We better close out on that one.
We are brought to you by the Butterfly Network. Dr. Dan Lasserson, thank you so much for joining us here. Really a pleasure to talk to you and pick your brain.
Thank you guys so much for having me. I've had a blast talking to you. I'm looking forward to what we're going to be creating in the near future. Really looking forward to this. Great space.
Absolutely.
Great space to
Absolutely.
Well, for Dr. Brian Schmutzler and Dr. Dan Lasserson, I'm Vahid Sadrzadeh, and this is Going Under Anesthesia Answered. We'll see you in the next one.